Welcome. I am Carol Berry, the Executive Director of CFN, and thank you for joining us for today's webinar, a national comparison of intensity of end-of-life care in Canada, defining changing patterns, risk factors, and targets for intervention with Rob Fowler and Andrea Hill. I also have Amanda Lorberg, Manager of Research in KT, joining us today to facilitate the Q&A session following our presentation. I'd just like to do a quick review of CFN's upcoming competition and webinar housekeeping items before I formally introduce today's two presenters. So just a reminder, please submit your questions online during the presentation today, and we'll try to answer as many as possible within the hour timeline. Both Rob and Andrea will be willing to answer questions that we're unable to get to today, and their emails will be posted on the final slide today. Also, as always, a short survey will pop up on your screen after the webinar, so we're hoping you can just take a minute to provide us with some feedback to either help us improve future webinars or provide feedback to our presenters, and we can share that with them after the webinar. We've already had a few questions that the webinar slides and the video will be available on our website for viewing somewhere in the time range of 24 to 48 hours. You can see the URL on the screen, and that's where you'll find them. You'll also notice our website is currently under construction. This is to improve the content, the impact section, the searchability, etc. And it will likely be a few more weeks before we reach the 90 or 80% website completion stage. So stay tuned. And of course, we welcome any of your comments or suggestions. For the upcoming webinars, unfortunately, we have to reschedule the December 5th webinar, which was the care of acutely ill older persons living with frailty with John Hurdes and George Heckman, due to some scheduling conflicts. Those who are currently registered will get an email notification likely later this week with the change of date. And as well, the new date for this webinar will be posted where you'd normally register for the CFN webinars. You'll see the URL there if you want to go and pre-register for the next few webinars that are on our website. We have one coming up Wednesday, January 9th with Leanne Singer, and we have one coming up Wednesday, January 23rd with James Downer, and you can see on the website what those topics will be. We also have a 2019 Hqp Training Competition. It's actually just closed, the intent to apply, and this is just a reminder for the full application packages due date of Tuesday, December 11th. Also, we have coming up a 2019 KT competition. The planned launch date is Monday, December 10th. So if you could, please continue to check our website and social media for updates on this competition. And we also have, for our Hqp, a video contest in process. We hope we get lots of entries. It's open to both the Hqp that are currently in our program as well as previous Hqps. There are prizes to be won. So the URL is on there for more details about this competition. So please send in your videos. So without further ado, I will introduce today's presenters. We have Robert Fowler, who will be speaking first. He's a senior scientist, evaluation, clinical sciences, trauma, emergency and critical care research program at Sunnybrook Research Institute. He's a physician and a professor of Department of Medicine and Interdepartmental Division of Critical Care Medicine at U of T. We also have Andrea Hill, who will be doing the second presentation, and her research, she's a research associate at Sunnybrook Health Sciences. Her research involves examining patterns and determinants of end-of-life practices. Other research interests are focused on epidemiology and outcomes of critical illness and injuries. So over to you. I think, Robert, you start first.
So thanks very much, Carol and Matt, and to the Frailty Network for asking us to speak today. And thank you so much for the support that you have given to all of the folks that work with you over the past 6 years or so. Andrea and I will present on behalf of a team of people that have worked with us over the past many years on a range of studies that have looked at end-of-life care in the Canadian perspective, and then drilling down where we have some additional and complementary information to the Ontario perspective. And I'll move on. These are a range of folks that have helped with funding over the past many years. And in addition to the Frailty Network, I would like to thank our institutions locally, Heart and Stroke, CIHR, CIHI, the College of Physicians and Surgeons in Ontario, and Statistics Canada. The only real disclosure beyond this is that one that we all share, in fact, that we probably are all biased towards wanting to improve end-of-life care, because it is one of the two great health events that are a certainty for all of us: birth and death. The usual North American trajectory at end of life. What do we know about it? The next slide will go over just a little bit about that. The four trajectories that I wanted to focus on, just on slide number 6, are ones that are cartoons, but I think they speak to the way a lot of us conceptualize end of life. Up in the top left corner, there's the notion that everything is well until some age in life and you die suddenly, perhaps historically a big heart attack in your sleep. Up in the top right-hand corner, we have a cartoon that talks about terminal illness. Maybe an example might be an advanced metastatic cancer, where you're doing well until there's something discovered, and then a rather rapid trajectory towards death. In the bottom left, one of organ failure that may be typical of COPD, congestive heart failure, where you have ups and downs, but a general downward slope from a period of reasonable function until you die. And then in the bottom right-hand corner, the notion of what people may have termed in the past sort of potentially old age or maybe frailty, that leads towards death in a sort of gradual and slow fashion, usually at an advanced age. And when we think about these trajectories, I think a lot of us imagine that we ourselves, as as people, as potentially as patients, will hopefully enjoy a relatively normal life until a certain age, and then we'll just die. But in fact, on the next slide, when we put proportions to these areas, we find that that notion that I think a lot of us hold is very uncommon relative to the other three. And I think this kind of notion about our own lives and how we might experience death influences a lot of our planning around end-of-life care and a lot of the health systems that have evolved towards helping us with some of these trajectories that often don't really map out to the frequencies with which we encounter them. On the next slide, we sort of just talk about things that actually lead towards death in North America. What's the evidence behind the things that kill us? On slide 10, we will look across the lifespan and see that in different categories of age, we have things that are very, very different in terms of causes of death. So at younger ages, I would say traumatic and external causes are the most common reasons why people might have a premature death. As you get into the middle parts of life, you end up having circulatory problems and cancer that start to become more common. And if you can avoid cancer-related deaths that happen in the middle parts of life, then eventually circulatory deaths become a very, very common cause of death over the latter parts of life. On the next slide, we see emblems of how we approach the notion of dying within certainly the Canadian context and the North American context, and increasingly around the world, that all of these individual causes of death we imagine can be beaten, or we can defy or deny death to occur. Much of this stems from, I would say, a war, so-called, on conditions over the years that perhaps started in the United States with the war on cancer during sort of the Nixon era, but has proceeded across many diseases and has certainly been embraced by many societies that try to improve the health of the population by focusing on certain diseases, and try to focus on fundraising a lot by promoting slogans that if we work hard enough, if we donate enough money, we can prevent death from certain causes. And inevitably that's true to some degree, but the greater inevitability is that eventually there will be something that takes us all. On the next slide, I wanted to mention what we know about some of the ways that we try to deny or defy death. So for instance, in that top left-hand quadrant from a few slides back, a lot of us think about sudden death as our most likely route towards the end, which is in fact not true. And a lot of our treatments are geared towards preventing that kind of a death. So much so that it's very common that we use things for all deaths that probably only really are good treatments for a small proportion of patients that die. For instance, CPR, something that is a ubiquitous part of in-hospital death, in fact, the default in most all of our hospitals, is successful, unfortunately, not that frequently. So among all of inpatients in a hospital, survival after CPR is only about 15%. A higher number for out-of-hospital cardiac arrest, oftentimes of a different etiology, but very uncommon as an effective treatment within a hospital. It's without a shockable rhythm, so that you can apply electricity to reset a ventricular tachycardia or fibrillation. Survival there is even less, it's at 10%. And in patients that are of advanced age with perhaps advanced medical conditions, survival drops into the single digits. And for those in the intensive care unit where Andrea and I often work, patients receiving vasopressor medications, forms of organ support already, survival is very, very small indeed. Yet, this is how we often approach death, certainly in a hospital setting, using very aggressive means, oftentimes, probably futilely so, to try to prevent things that can't be prevented. The next slide speaks to, however, what we might see portrayed in the most common source of medical information that we have, probably also as healthcare interested folks, in addition to the public. And so this is the best research project ever constructed, where you were asked to look at television shows and count how many people survive of those that have some form of a cardiac or a respiratory arrest in the confines of the half an hour or so of the television. And in fact, on Chicago Hope, 64% of people that had CPR survived to the end of the episode. On ER, 68%, Rescue 911, everybody survived. So fully 3/4 of people, more than the inverse of what we know actually happens, survive after a heart-stopping or a lung-stopping event receiving CPR. And I think to some degree, this influences what we, and certainly what the public, imagines is possible. And again, speaks to the notion that we have focused on a culture of, denying what is inevitable for all. And it influences, again, the kind of care that we have probably set the system up to provide. On the next slide, I wanted to look at where it is these days that Canadians die. And we'll go over on slide 16 some of the trajectories. First, in Western Canada, we can see that roughly half of people are still dying in a hospital setting. A minority of patients in the era sort of preceding this publication in the mid-2000s receiving palliative care, and certainly a minority of patients dying at home or in other locations. On the next slide, in Eastern Canada, we see that perhaps there is an even greater proportion of patients dying in the hospital. And if we advance just one slide, there's probably, and I recollect from my own upbringing in New Brunswick, a greater proportion of patients that will be dying in hospital, and oftentimes I would say fewer resources to help people die in other settings. On the next slide, we wanted to look in greater detail across the Canadian spectrum in a contemporary sense. Patients are in the healthcare system at the time of death. And Andrea is going to walk through a very interesting project that helped to combine a number of data sets towards that answer. Andrea, I'll let you sort of take control.
Okay, thanks, Rob. And I'll ask the folks at the network to just continue to progressing the slides. Thank you, everybody, for listening in to us today. As Rob was saying, one of the challenges of understanding the patterns of end-of-life care at the national level has been that our different data systems across provinces and institutions haven't really been speaking to each other. But the recent pilot linkages of Statistics Canada's Vital Statistics Death data set to CIHI's health administrative data has been an important step forward. This allowed us not only to capture deaths occurring both in and out of hospital, but provided us a means of looking at several indicators of acute care utilization by dissidents in the period approaching death. The next slide shows the study that Rob just mentioned, and this is the pan-Canadian look at end-of-life care. Specifically for this presentation, we use the Vital Stats death data for all provinces excluding Yukon and Quebec for the years 2007 to 2012, and we used these deaths were linked to the CIHI data for discharge, the discharge abstract database, which is the information about acute care admissions to hospitals. And we use the National Ambulatory Care Records to identify use of ED visits by our dissidents. And I should mention that this is limited to Ontario and Alberta. The NACRS data is limited to Ontario and Alberta, as they are mandatory required, the only provinces that have mandatory submission to CIHI for ED data. So if we go to the next slide, this is the dissident cohort that we identified. So we identified about 930,000 dissidents that we were able to capture both in the StatScan data set as well as the discharge abstract data set. So they were primarily men, with about a third identified as frail and receiving palliative care respectively. I should note here that our identification of frailty was based on using ICD-10 diagnostic codes during a hospitalization within the year before death. And we similarly identified in hospital-based palliative care, looking again at relative diagnostic and provider service codes during an hospitalization. In terms of where people died, consistent with the findings from the earlier study from the Atlantic and Western provinces that Rob just walked you through, we found that over 60% of dissidents died in a hospital. And as you can see in the next slide, across all years and all provinces, hospital was the primary location of death, with the national proportion ranging from about 59 to 63%, with some but not all provinces showing a slight decline in the proportion of deaths over time. The next slide, we wanted to take a look at the receipt of palliative care among those who died in hospital. And as you can see here, about 50% of Canadians received hospital-based palliative care based on this national look within the last year of life. And this was somewhat variable across the provinces. To continue our look at palliative care, the next slide shows the proportion by frailty status. And you can see that there were no marked differences in terms of comparing non-frail and frail individuals in terms of the receipt of palliative care in the last year of life. While we cannot really identify, other care settings such as in-home or other care facilities, these data are consistent with evidence from the individual provinces showing that this care is infrequently provided to dying Canadians. Additionally, these data do highlight the need to understand the reasons for the observed variability across the provinces. And I would suggest that they may offer opportunities to address potential gaps in end-of-life care. In the next few slides, I will show some of the results from our investigations of acute care resource use by dissidents in the period approaching death. In starting here with a look at the healthcare use by frailty status, you see that within the 6 months prior to death, with the exception of visits to the emergency room, by and large, non-frail individuals were more likely to be admitted to hospital and to use more technologically laden care, including, for example, admissions to ICU and being mechanical ventilated. But regardless of frail or non-frail, again, as the overall data did point to, a significant amount of, a proportion of individuals do use these services in the last 6 months of life. In the next slide, it walks us through what the entire dissident population looked like at different proximity to death. Again, we see a substantial use of acute care-based services, including in almost 3/4 of dissidents being admitted to a hospital within the last 6 months of life. While the proportion did decrease at 30 days, at 30 days prior to death, the admission was still very high, with 1 in every 2 dissidents being admitted. And this was pretty consistent across the provinces. Similarly, in the next slide, you will see here that in terms of acute care use, in terms of admission to ICU, at 6 months, 1 in every 5 dissidents was admitted to an ICU. And at 30 days, this figure again declined somewhat, but it was still 13% of individuals that were admitted to the ICU at 30 days prior to death, with marked variability in ICU admission across the provinces. The next slide shows the rates of mechanical ventilation across the provinces. And again, you can see that the provincial level variability in the use of these types of aggressive life-sustaining technologies is consistent when we move to mechanical ventilation, showing again that a substantial proportion of individuals do continue to use acute-based care health services in the period approaching death. Again, the large proportion was pretty consistent across the provinces. And this, in our mind, suggests that there's a lack of structures to support non-acute care-based care, including, for example, hospice, palliative, or home-based care. And this is a consistent theme across the country. Our data, we feel, does underscore the need for a national response, an approach to end-of-life care in Canada, which I know that everybody would support. Also, while it's not clear from our data what the right amount of healthcare use is, for example, what is the right amount of ICU admissions, the variability that we saw does suggest that there's something more that we can learn about what is best for individuals and their families. So if we move to the next slide, please. I wanted to walk you through one of another project that we used a rich linkable data sets available in Ontario. We wanted to do a more deep dive to look at population level rates of use of end-of-life practices across the population. And because Ontario has a set of rich linkable data sets, we were able to concentrate and focus our attention here. So in this study, our cohort included all dissidents in Ontario between 2004 to 2015. And as I mentioned, we used data sets that are available at ICUs, which is the Institute of Clinical and Evaluation Sciences, in order to look at end-of-life care practices. And in the next couple of slides, I will summarize some of the data that we have with respect to trends in location of death and patterns in receipt of palliative care in the 6 months prior to death. In this slide, you can see the temporal trends in the location of death in Ontario. And you can see about 45% of dissidents died in hospital over the period. And again, this number will be slightly different from the national numbers that I showed you, just because, you know, the time difference, and also we're looking at the population level. So we saw a slight decline in the proportion over time, and a concomitant increase in deaths at home. So the deaths in hospital increased, and deaths decreased, and deaths at home increased. But of interest is the proportion of hospital deaths that included palliative care. And that's the light blue line that you're seeing on the screen, ranging from about 14% in 2004 to about 29% of all dissidents by the end of our study period. If you move to the next slide, please. So with the Ontario data, we're able to describe palliative care use across a range of sectors and providers, including, for example, the home care setting, long-term care, and primary care. And when we looked at receipt of palliative care in the 6 months before death, we see that regardless of where individuals died, there was a marked increase in the proportion receiving palliative care over time. And while we can't really tell to what extent these data reflect changes in coding practices over time, they are encouraging. However, it should be noted that similar to the national data, a significant proportion of individuals still don't receive palliative care, and there's still some work to do in this respect. And we would offer that some of this work should involve establishing which models of palliative care services is effective in improving the quality of care we provide to dying individuals, and the impact that this type of different care would be on our health system in terms of health system costs as well. I will now turn the presentation back over to Rob, who will provide some additional data from our Ontario study.
Great, thanks, Andrea. And so in the last bit, we wanted to talk about another project that stemmed from clinical, I would say, experience and observation. And we'll drill down on the Ontario perspective again, just because of some of the granularity that we're able to achieve with more local data sets. And we wanted to ask you, are there differences in end-of-life care within certain segments of our population? And we'll go to the next slide. So Canada is an increasingly multicultural country, and that change over time allows us the ability to ask questions about end-of-life care with respect to perhaps where people come from in the world, maybe differences in culture, maybe differences in ethnicity. And if we look at the number of immigrants who have come to Canada over the last 150 years or so, we see that there are different waves of immigration, often changing around periods of war and displacement in the world. But on the next slide, we see, in fact, that the kinds of immigration, and particularly where people have immigrated from, has changed dramatically over the last 100 years. Whereas Canada used to be a country populated most commonly by folks from Northern and Western Europe, increasingly we have had over the past 30 to 40 years immigration from throughout the world, particularly so in East, South Asia, and Africa. On the next slide, we present a bit of a framework, wondering if end-of-life care may be influenced by the region from where someone comes in the world. And there are so many factors that might go into this equation, and we've listed just a few of them here: health literacy, communication, resources, preferences, and values that may be influenced by someone's ethnicity, someone's culture, perhaps other issues that track very closely with where they were born and perhaps where they grew up before coming to Canada. And we wondered if those that have recently immigrated to Canada receive different end-of-life care than long-standing residents. On the next slide, there's a reference to a publication from just about this time last year that you can find more details than we'll prescribe here today on exactly this question. And I'd like to give a special note of thanks to Chris Yarnell, in addition to the other authors on this paper, who did such terrific work to try to examine the question that we posed. On the next slide, it's a rather busy slide, and I'll go through it with a series of bars to try to help bring some clarity to it. So next slide highlights the location of death among a number of different groups of patients: long-standing residents, recent immigrants, the differences between those two, unadjusted relative risks of dying in one place versus another, and then trying to account for all factors that may be different among different parts of the population, some of those that we mentioned on the prior slide, trying to get to what is the influence just of this notion of immigration and or prior culture, prior ethnicity perhaps. On the next slide, we look at, in addition to location of death, care received in the final 6 months of life along hospital admissions, ICU admissions, mechanical ventilation, dialysis, feeding tube insertion, and tracheostomy insertion. All of these markers we feel of some degree of aggressiveness at the end of life, and to see where these signals lie. On the next slide, we're going to highlight just the differences in those two large categories between long-standing residents and recent immigrants. And we'll see that there are, in fact, some differences between these populations. If we look at, in brackets, the proportions of patients dying in an ICU, recent immigrants more commonly dying in an ICU. And we'll look down to the care received in the final 6 months of life as another marker of perhaps aggressiveness of care, finding, in fact, that patients coming from a recently immigrated perspective more likely to be admitted to hospital, more likely to have any kind of ICU admission, more likely to be placed on a ventilator, receive dialysis, have a percutaneous feeding tube, and perhaps even having tracheostomy tubes. So all signals that line up in the direction of recent immigrants receiving more aggressive care at the end of life. On the next slide, we'll look to the unadjusted relative risk of our primary outcome in this investigation, location of deaths, finding that there's about a 55% greater likelihood that if you were born outside of Canada, as opposed to being born inside of Canada, you would die in an intensive care unit. On the next slide, we highlight similarly increased relative risks for most of the procedures that we pre-specified may be markers of aggressive care if you had recently immigrated to the country. On the next slide, we're going to break this down a little bit in terms of certain characteristics of all of those that were in the study and dying. And what we would see, and I'm going to highlight just a few things on this next slide by arrows. We'll move to the next slide for the first arrow, showing that the relative risk of dying in an intensive care unit, looking at the comparison of recent immigrants and longstanding residents, seems to increase depending upon increasing age. The next arrow looks to that gradient that I think, again, speaks to perhaps almost a dose response function of your life prior to being in Canada. On the next slide, sort of highlight that, in fact, there perhaps wasn't a large difference depending upon where you lived or where you immigrated to, at least in the bands of strong to weak urban areas. And we can see that highlighted with our square. On the next slide, one of the most interesting things, and I'll highlight this just on the following slide and graphic, is that the region of birth, so where it was that you were born in the world before coming to Canada, now just looking at recent immigrants, shows an interesting gradient, if you want. And the gradient sort of speaks, and if you focus on some of these lines, that if you are a recent immigrant from Northern or Western Europe, you in fact were less likely to die in an intensive care unit than all other recent immigrants. If you were immigrating from North America, in our context, this meant the United States, you were perhaps slightly, but non-significantly, more likely to die in an intensive care unit. But then from Southern Europe, Eastern Asia, parts of Oceania, Central America, the Caribbean and Mexico, South America, Western and Central Asia, Africa and South Asia, you create this gradient. And on the next slide, you can create a map of the world, if you want, and put the relative risk of dying in an aggressive care setting in the intensive care unit according to the region of birth and the region from where you immigrated. On the following slide, and by the next slide with an arrow, it's an interesting observation that the greater the amount of time that you spend in the Ontario geographic context after immigration seems to diminish that likelihood that you might find yourself in an intensive care unit at the end of life, just at the time of death. And on the next slide, I'd like to say thank you very much to those that are on and listening. And again, thanks so very much to those that have helped to support this work, particularly so the Canadian Frailty Network. And I think we'll stop there, and hopefully Andrea and I will be able to entertain a few questions.
Yeah, thank you, Rob and Andrea. Excellent presentation. I learned lots. And we'll now start our Q&A. So please, everyone, please continue to submit your questions. And over to you, Amanda. There's a few here already.
Great. We have some questions coming in. We'll give a few minutes for more to come in. But the first one is asking you to speculate whether there are some reasons why more aggressive treatments in intensive care is higher in Ontario compared to other provinces in the last month of life. So we saw that in that one of those slides that Andrea presented, I believe. Mm-hmm.
Andrea, do you want to take a stab at this, or it's a tough question?
Yes, I mean, one could speculate that in terms of perhaps, and I've not looked at this, in terms of beds per capita, that might explain it, that we might have more intensive care resources, and and that might be a marker for use as well if the resources are available. But that's something that I would, that we definitely have to look into.
It's hard, and it's hard probably to come up with to come up with an answer that represents sort of the truth. I think, as Andrea said, and we've speculated a lot in doing work previously looking at ICU beds across the country, we do see that there are differences in different regions, and it's interesting, and I wouldn't have expected this sort of upfront before doing this work, but in Ontario we're sort of at around sort of the national average, or maybe just a little bit little bit beyond with ICU beds. In the eastern provinces, again, where I grew up in the Maritimes, there are, relatively speaking, more ICU beds than ward beds. And if you work in that system, it probably doesn't seem the case, but relative to other parts in the country, that's true. And as Andrea said, that may influence, in fact, where we end up being able to care for patients at the end of life. I think there are also differences, certainly in very populous areas within sort of major cities in Canada. And Ontario is a good example of that, certainly in the Greater Toronto area, of a very sort of diverse population with respect to certainly immigration, ethnicity, and I think in the last slides we sort of touched on some of what I think are very real differences in approaches to care at the end of life based upon your culture, ethnicity, and I think we may see some of that in the Ontario context a little bit differently than in some other provinces.
Yeah, that's a really good point. I'm sure it's multifactorial, and so in terms of the multiculturalism, do you think that a language barrier may be a reason for the lack of advanced care planning?
Undoubtedly, that's a factor, and there are so many things that conspire towards us not engaging in advanced care planning for, all patients in the population, that I think any additional potential barrier, language would be an obvious one, will probably make it even harder.
Mm-hmm. And do you perceive differences in end of life and palliative care by different patient groups in your areas?
Well, I think that underlies a bit of the flip side of why we had asked the question for that last study, even though we were focused originally upon care delivered in an ICU and markers of aggressive care. Again, the alternative way to look at this is whether or not there may be differences in palliative care by ethnicity. And although we didn't present that exactly, I think that my clinical experience would say that there are differences in the timing by which different groups in the population will approach palliative care. And from that, I mean from the patient and the family's perspective, perhaps from the provider's perspective as well. And I think that, that some of the notion around communication and sort of complete communication around a trajectory towards death probably doesn't happen as effectively or as fully when there may be anything that interrupts that natural communication. Some of it might be language. Some of it might be starting from, if you want, a shared position with respect to expectations and usual approaches that often tracks very closely to culture.
Great. I can appreciate that there's a lot of challenges in all these databases that you're amalgamating for your study. But in terms of receiving palliative care, how was that defined? Like, was this, for instance, like a Z code, or was it an admission to palliative care service, or?
That's a great question, and it's one that's sort of changed over the years with differences in coding. Andrea, do you want to take a stab at that one?
Sure. With respect to the national data set, we were somewhat limited in terms of what we could do. So there, I think the reference is on the slide, but there was a paper that came out that tried to do this within the context of health administrative data set and looking at discharge abstracts after acute care. So what it does is it identifies several frailty syndromes, for example, delirium, dementia, and functional dependence, to name a few. And we, working with High, we mapped the ICD-10-CA codes to these frailty syndrome and defined for this study frailty based on the presence of one or more of these conditions. So we recognize that, yes, there's limitations. Within the Ontario data set, we were able to do this a little bit more broadly, again, given the different data sets and our ability to link across data sets. Again, it's still administrative data, but we were able to look at, we expand, in addition to looking at these hospital-based type codes, we're able to look at, palliative care billing codes through the Ontario Health Insurance Plan, for example, and the receipt of these services in long-term care settings and so on. Again, it restricted again to either some type of billing codes, whether it be in the home care setting or the long-term care setting or hospital setting, and diagnostic codes.
Great, thanks. It sounds like a lot. We have a question here about your study you mentioned was limited to acute care hospitals, but Ontario, we have several sort of larger palliative care units in non-acute facilities. And thousands of people die in these units and receive palliative care, but have these been accounted for in your analysis, or have you sort of stated that as a limitation?
Andrea, do you want to field that one too?
Sure. So if you're talking with respect to the Ontario data set, it would be palliative care receipt across all health sectors, including those units. We wouldn't be able to specifically say it was within the palliative care unit, but if it was based on a physician billing code and the physician provided the care within those units, then we would capture some of that palliative care. And for sure, there's a limitation because we can't capture it all. If our methods of looking at this is not as accurate as we'd want, but we do get some of that information from the Ontario data set. Unfortunately, the national data set, we were restricted to just the codes that were in the discharge abstract database. And again, those would be the type of service, for example, provider that the patient was assigned to, or the palliative care diagnostic codes within the DAD. Does that answer the question for the?
I think so. I mean, I don't know for sure, but that does clarify for sure. You have another question, wondering whether or not you've looked at the controlling for age in where recent immigrants versus longtime residents of Ontario are having more aggressive care. So this individual is wondering whether recent immigrants are dying younger, and so more aggressive care might be more reasonable to try because they are of a younger age.
That's a great question, and one that we, I think, do see in most of the looks that we've had across different data sets around more aggressive care to younger people. We were able to, in the last study that we went over, separate out age and other effects in that adjusted analysis, and while there can always be some residual confounding for many of these variables, as much as possible we were able to take age out of the equation, at least from the perspective of the adjusted analysis presented.
Okay, great. I think we might have time for another one just before we kind of wrap it up here. What about if you were to measure frailty differently? So you mentioned the definition was on one of your slides. How do you anticipate your results? You would see differences depending on which type of frailty measure you're using. And I appreciate that there might be differences with the database.
That's a very good question. I mean, maybe Andrea and I can both take a stab at this. Defining frailty, I think, is one of these things that we could spend weeks on and not really get to an absolute sort of definition that spoke to all of us. And I think it's been one of the terrific things that the network has been able to do, is to try to bring people together to talk about what frailty really means. Defining it in the context of health administrative data sets is a is another take on this challenge, because we're limited in what we have. And often many of the measures that we might use clinically in clinic at the bedside, whether it's a frailty scale or perhaps score, we just don't have some of that information retrospectively. And so we're often limited by using diagnoses that may map to greater or lesser degrees with frailty as defined in other primary measures. And so we're a bit limited, to be sure. And I think that it would be, I don't know, just speculation on my part, if we were to use maybe more sensitive or less sensitive definitions, how we might find the results moving. That's not a very helpful answer, other than to say I think there are many different ways that we can define it, and certainly there are evolving ways, even within the health administrative data set world, about defining frailty. Andrea, do you have any thoughts on that?
No, I agree with you. It would be, I mean, as we all know, it's very limited in terms of what we can do with our health administrative data set in defining, you know, these concepts. So, and I like you wouldn't hazard a guess in terms of which direction our results would change had we had a different measure of frailty.
Great. I know it's going out with a real thought provoker, but do you have any closing comments?
Well, I mean, one of the comments I'd like to highlight is that while a lot of people have been doing work with patients who are frail for a long time, I think the network has really helped to catalyze more and more interest from whole groups of people in healthcare and beyond that weren't able to work in this space before, and so it's not really a thought as much of as it is a thank you for the support to so many folks in this area.
Andrea, do you have any final thoughts to convey before we sign off?
No, I'm good, and I just want to echo Rob's sentiments of thanking the network. I think this has been a tremendous opportunity for us to move these projects along over the last several years, and we're grateful for the support from the network.
And we are very grateful for you presenting today. And so I guess that kind of concludes today's webinar, and we look forward to everybody joining us on our next webinar on January 9th. And your pop-up survey will come up if you can take a moment to complete that. And I wish everyone a good rest of the day. So that's it for today. Thanks for joining.